Hello everyone, welcome back to the Pharmacotherapy series on Pharma Palette. In the previous video, we have seen the introduction till the diagnosis of the cardiac failure. Now comes the most important part, the treatment. Heart failure treatment may look complicated because there are so many drugs, but if you understand the flow of the treatment, it becomes much easier. In this part 1, we will be simplifying all these topics with easy explanations and simple exam focused points. And remember, in pharmacotherapy, we should focus mostly on why the drug is used and what problem it corrects. Without any further delay, let's get into the video. The main goal of the treatment for the heart failure is to improve the quality of life, to reduce the symptoms, and to minimize the hospitalization. Coming to the general approach, there are different staging systems like ACC and AHA. So, ACC means it is American College of Cardiology, AHA, American Heart Association, has developed certain guidelines that gives 4 different stages A, B, C, D. So these are useful for telling the exact progression of the heart failure, like in which stage the heart has failed. So to tell the progression of heart failure, this staging system is useful. So coming back to the different stages under this general approach. So the first one is stage A. In this stage, there is no structural heart disease. The main goal is to prevent the heart failure. Coming back to the management under this, just remember the trick as HBDCS, where H means it is healthy lifestyle, B means BP control, D means diabetes control, C means cholesterol reducing, S means it is stop smoking. So these are the management under the stage A. Coming to the second stage, which is stage B, here there is a structural heart disease, but here there is no symptoms. And here the goal is to prevent the progression of the heart failure. Coming back to the management, in this we will be continuing with the same stage A measures. You can give the ACE inhibitors, ARBs, or beta blockers, that to evidence based beta blockers will be given. And in case of if the patient is having myocardial infarction or if there is reduced LVEF to the patient, in that conditions along with these drugs you will be adding a statin drug. Coming to the stage C, here there is a structural heart disease. Along with that, symptoms will be present in this condition. So here the main goal is to reduce the symptoms, to reduce the mortality, and to reduce the hospitalization. Here the main treatment we will be providing, the patient will receive the GDMT, which is simply the guideline directed medical therapy. So in this guideline directed medical therapy, the patient will be receiving any of these 3 drugs like AC inhibitors or ARBs or ARNI. So any one of these 3 will be given. ARNI is the new drug, that is angiotensin receptor neprilysin inhibitors. Coming to the selected patients, some drugs like digoxin, ivabradine, hydralazine or isosorbate dinitride will be provided. So coming to the stage D, so this stage is also called as advanced heart failure or the refractory stage. So in this we will be, main goal is to reduce the symptoms and to provide the advanced care. Here the management is to transplant the heart or to use certain IV inotropes. So these kind of specialized interventions will be provided. Coming to the non-pharmacological therapy, first one is to reduce the salt intake. Usually it should be less than 2 to 3 grams per day. Second one is to restrict the fluids. It should be less than 2 liters per day. Third one is to check the body weight regularly. Fourth one is the cardiac rehabilitation, which usually includes the exercises and some kind of lifestyle modifications. And the last one is to remove certain causes like CAD or the drugs which are causing this heart failure or the drugs which are causing the worsening the heart failure. So those kind of causes should be removed. Coming back to the pharmacological therapy, so the first class in the treatment of heart failure is the diuretics. Usually in the diuretics condition, the body will be retaining certain substances like salt and water, which leads to the swelling, finally leading to the lung congestion. So usually in the diuretics in heart failure, we will be using thiazide diuretics or loop diuretics. When you use a thiazide diuretics, these are not given alone. This will be combined along with the loop diuretics and then given, because that produces the stronger effect to the body. So coming to the examples, hydrochlorothiazide and metalazone will be given. And this thiazide diuretic, it is a mild diuretic. So it is useful for producing the mild fluid retention, and it also helps in treating the high BP conditions. And coming back to the second class, that is loop diuretics. So loop diuretics, the best example is the furosemide, and that too it is given at a dose of 20 to 40 mg per day. And if you see, one of the brand of this furosemide is Lasix. And coming to this loop diuretics, these are the main diuretics used in case of heart failure, because this will be strongly removing the excess fluid from the body. And coming to the main ADRs of this loop diuretics is, just remember the trick as KVNMT, where K means it is kalemia, hypokalemia, V means it is volemia, hypovolemia, N means it is natremia, hyponatremia, M means it is magnesiemia, hypomagnesemia, T means it is hypotension. Along with that, all this KV, NMT are in the hypo condition, and in the loop diuretics there are some other ADRs which will be in hyper conditions. One is hyperuricemia, and sometimes it causes the renal dysfunction as well. Coming back to the second class, which is ACE inhibitors. The ACE inhibitors will be inhibiting the conversion of angiotensin 1 to angiotensin 2, which will be resulting in the conditions like decreased vasoconstriction. That means it leads to vasodilation, decreased BP, decreased fluid overload, and ACE inhibitors will increase the bradykinin. Because of this increase in the bradykinin, we will be having the side effect cough. And coming to the therapy in case of heart failure, so AC inhibitors are usually started with the low dose, then slowly the dose will be increased till it reaches the target dose. And for every 2 weeks, the dose titration, that means doubling of the dose will be doubled for every 2 weeks. So like that, the therapy is started. And coming back to the ADRs, the main ADRs, to remember that, just remember the trick as hack. For AC inhibitors, the side effects trick is hack. H means it is hypotension, A means angioedema, C means cough, K means it is hyperkalemia. Sometimes renal dysfunction can also occur. Coming back to the contraindications, remember it as PAK. So it is contraindicated in the pregnancy and in the patients who are having the history of angioedema, and if the patient is having any kind of kidney issues, AC inhibitors are not prescribed. And this, whenever you're giving AC inhibitors to the patient, you need to monitor certain conditions like BP, potassium levels, and the kidney function. You will check this before the treatment, 1 to 2 weeks after the treatment, and also after increasing the dose also you will be checking these readings. Coming back to the next class, the angiotensin receptor blockers, ARBs. So, in this ARBs, the main mechanism is to block the AT1 receptors. When the AT1 receptors are blocked, it will be inhibiting the effects of this angiotensin 2. That's where it leads to the conditions like vasodilation, decreased BP, less fluid retention, and less heart remodeling. And in this, when ARBs are given, bradykinin is not increased like AC inhibitors. So, when ARBs are given, the chances of getting cough and the chances of developing the angioedema will be reduced because bradykinin is not increased in this ARBs. Coming back to the uses, so this will be given in case of heart failure, it is given in case of hypertension. It is given in the patients who are not tolerating this AC inhibitors, because these AC inhibitors will increase bradykinin, increases the chances of getting this cough and angioedema. So if the patient is intolerant to AC inhibitors, this ARBs will be prescribed. So in the side effects, just remember the code HKRD, where H means it is hypotension, K means it is hyperkalemia, R means it is renal dysfunction, and D means it is dizziness. And coming to the contraindication, this is not given in case of pregnancy, and this is also not prescribed if the patient is having any kind of kidney failure. And coming back to the examples, so Valsartan, Candesartan, Losartan. Valsartan is given at a dose of 20 to 40 mg twice in a day. Candesartan is given at a dose of 4 to 8 mg once in a day. Losartan is given at a dose of 25 to 50 mg once in a day. So coming back to the next class, the ARNI. This is one of the important class under this heart failure drugs. Angiotensin receptor neprilysin inhibitors. So coming to the example, so this is having both sacubitril and valsartan at a dose of 49 to 51 mg given twice in a day. So coming to the mechanism of action, usually this ARNIs will be acting by opening the vessels. When the vessels are opened, extra amount of the fluid will be removed from the body, thereby causes the inhibition of this harmful angiotensin. So the effects of angiotensin will be reduced. And this will be acting by, this ARNIs will be acting by two ways. One by the sacubitril mechanism, one is by the valsartan mechanism. If it is sacubitril, it will be inhibiting this neprilysin enzyme, due to which the body has more natriuretic peptide and bradykinin, which will be again leading to the conditions like vasodilation, increased sodium and water loss, decreased BP, and reduces the heart stress. Coming to the valsartan, usually this valsartan is an ARB component, so it will simply inhibit the AT1 receptors, which will be causing this less vasoconstriction. That means it causes vasodilation, reduces the aldosterone levels, and also reduces the heart remodeling. So coming back to the uses, this is used in case of the heart failure, especially from class 2 to class 4 heart failure. This drug can be prescribed. This is also used in the HFrEF condition. And so there are certain guidelines which state that both AC inhibitors and ARBs can be replaced with this ARNIs because they are having the better benefit. If a patient is on ACE inhibitors, you need to stop it for 36 hours before giving this ARNIs, because this will be preventing the conditions like angioedema. So this is called as the washing out period. So coming back to the ADRs of this ARNIs. So first common ADRs are like, just remember the trick as DRCH, where D means it is dizziness, R means it is worsening of renal function, C means it is cough, H means hypotension and hyperkalemia. Coming to the serious adverse drug effects, angioedema, and this angioedema is most commonly seen if the patient is on these drugs, sacubitril and valsartan. This angioedema is common. And coming to the contraindications, it is not given to the patients with pregnancy, and it is not given if the patient is having the conditions like angioedema, and this is not given if the patient is on the AC inhibitors or ARBs. Till now, we have completed the main pharmacotherapy of heart failure. We learned the general approach, stages, non-pharmacological therapy, and 4 different classes of drugs and their mechanisms and how are they used in the heart failure. And if you see, most of these drugs are having the mechanism similar to that of hypertension. So before the next video comes, revise these topics once again and be perfect with this. And remember, pharmacotherapy is not about mugging up hundreds of drugs. It's about understanding how the drugs help in the disease. So one concept at a time, one revision at a time, and slowly even the difficult topics become easy. So in the part 2, we will be simplifying some other classes of this heart failure. If you found this video helpful, don't forget to like, share and subscribe to Pharma Palette. See you all in the next one.